From Microbe TV, this is Infectious Disease Puscast, Episode 12, recorded on September 28th, 2022. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. Now, on to the literature, shall we?
All right. So we will start with viral. And I wanted to remind people to listen to TWIV clinical updates for COVID, monkeypox, polio, enteroviruses, all kinds of stuff. But to start with a public service announcement for monkeypox, there is now a trial to look at the efficacy of TPOXX, tecovirimat, the oral antiviral for monkeypox. So if you get diagnosed with monkeypox, if you make a diagnosis of monkeypox, go to www.stomptpox, so STOMP, stomp, TPOXX, TPOXX.org/Maine. Let's get folks enrolled. Let's find out if this medicine works, how this medicine works, when this medicine works. All right. Well, I wanted to spend a little time on the article Compassionate Use of Long-Acting Cabotegravir plus rilpivirine for people living with HIV in need of parenteral antiretroviral therapy, published in HIV Medicine. Now, this article deals with what I think is a challenging subject. Just a little bit of background. I don't know if all of our listeners, I assume not all of them, dabble in the field of HIV therapeutics, but long-acting injectable cabotegravir, an integrase strand transfer inhibitor, and long-acting injectable rilpivirine, a non-nucleoside reverse transcriptase inhibitor, are components of a novel two-drug antiretroviral therapy, ART, regimen for the maintenance of virological suppression in people living with HIV infection. So the phase 3 Atlas and FLAIR studies demonstrated non-inferiority of intramuscular cabotegravir long-acting and rilpivirine long-acting administered every 4 weeks to daily oral standard of care ART in virologically suppressed adults at week 48. Now, the wonderful thing here, cabotegravir LA and rilpivirine LA can be administered every 8 weeks. This was shown to be non-inferior to administration Q4 weeks in the phase 3B Atlas 2M study. Now, this really sounds like a game changer, except for the huge and in many cases insurmountable challenge of actually getting patients access to this medication with a cash price of over $4,000 for the 4 ml injections. Physicians could request compassionate use to access the two-drug intramuscular administered ART regimen consisting of these agents for people living with HIV. And in this print, most 63% achieved or maintained virological suppression with this intramuscular injection. All right. The article, Predictors of Hospitalization and Superinfection in Viral Respiratory Tract Infections Between Influenza and Paramyxoviruses, the Superfluous Study, was recently published in JID. What a title. These are the results of a retrospective multi-center cohort study in the hospital group of the Parasite L'Île-de-France University, France, from October 2016 to June 2018. Data from the virological laboratory was obtained to identify all adult patients who had PCR evidence of a respiratory tract infection. They were looking for bacterial superinfections on top of these viral infections. In this study, they looked at 590 patients that had viral respiratory tract infections. Certain superinfections were defined, a certain superinfection was defined as a viral episode associated with documented bacterial infection, documented by blood or sputum culture, antigenuria, or intracellular bacterial PCR. required antimicrobial therapy. A possible superinfection was defined as a viral episode without bacterial documentation, but for which antibiotic treatment was maintained beyond 48 hours based on clinical data and complementary results. They reported how much bacterial superinfection. 56% of these individuals with these viral infections had a bacterial superinfection. Among the certain superinfections, several were due to strep pneumoniae, Haemophilus influenzae, Staphylococcus aureus, Enterobacteriaceae, Pseudomonas aeruginosa, and a bunch of other microorganisms, including 13 cases where the superinfection was polymicrobial. So just my nod to Hickam. Occam was not a physician. You can have more than one thing. John Hickam was a physician. You can have as many diagnoses as you darn well please. All right, moving on to bacterial, and be sure to listen to TWIM this week in microbiology. The paper Effectiveness of Different Antimicrobial Strategies for Staphylococcal Prosthetic Joint Infection results from a large prospective registry-based cohort study was published in OFAID. I think we do a lot of joint infection stuff, Sarah. What's going on?
Yeah, I don't know what it is recently.
As far as background, the authors suggest that treatment of staphylococcal prosthetic joint infection usually consists of surgical debridement and prolonged rifampicin combination therapy. They looked at the effectiveness of several alternative antibiotic strategies in patients with staphylococcal PJI. This was a prospective, multi-center, registry-based study. All consecutive patients with a staphylococcal PJI treated with debridement, antibiotics, and implant retention, DARE, or one-stage revision surgery between January 1st, 2015 and November 3rd, 2020 were included. Patients were treated with a long-term rifampicin combination strategy in 2 centers or a short-term rifampicin combination strategy in 3 centers. 200 patients were included, and adjusted hazard ratios for failure in patients treated with short-term rifampicin combination therapy were almost equal to patients treated with long-term rifampicin combination therapy, adjusted hazard ratio of 1.21, and that 95% confidence interval went all the way from 0.34 up to 4.40.
Yeah. So my next one, I'm going to just start with a question because I think everyone probably has a slightly different answer to this, but how long do you treat patients with Pseudomonas pneumonia? I think most people say it depends, like everything else in ID. But this paper, which was published in CID, is entitled Less is More, ? Antibiotic Treatment Duration in Pseudomonas aeruginosa Ventilator-Associated Pneumonia, or I'm going to say VAP. So this was a narrative review of some of the landmark trials investigating Pseudomonas VAP treatment duration. And so many, based on the 2005 pneumonia guidance, used sort of a 7-day duration for pneumonia with the ... unless it's Pseudomonas, where people were often giving 14 days of therapy. And then the updated pneumonia guidelines from ATS and IDSA in 2016 then favored 7 days for all patients' pneumonia, regardless of the organism. And this was based on a meta-analysis finding no differences in mortality or VAP recurrence, even looking at subpopulations with non-lactose fermenting gram-negative bugs. But this paper is really nice because it gives a deeper dive into those results, pointing particularly to sort of inappropriate or misapplied use of some of the included, specifically a prospective open label trial that actually, when you dig into the details, did not include patients with non-fermenting gram-negative VAP, as well as the idiapacin, I don't actually know how they want to say it, a trial, which you actually covered on Puscast, I guess a couple weeks ago now. I think the big issues are that there are probably patients who could do 7 days, but the ones that I think we worry about, like immunocompromised hosts and older patients, that risk of recurrence with shorter therapy is probably still there. And we do have a recorded episode of Febrile that hasn't come out yet that I have to edit, but just talking a little bit about VAP, not necessarily about Pseudomonas, but I think this is a really nice summary of this kind of gray area that I think people have different practice patterns on. So I don't know what you do, Daniel, but I worry a lot about the immunocompromised folks, and I feel like we'll sort of lean towards 14 days, barring something being super unimpressive. But
Yeah, this is tough, Sarah. I have to say, like, when I switched over, I never went back from the switching over from just 7 days to the 14 days for MRSA, for Pseudomonas, a couple other pathogen driven pneumonias. And it's not that they don't get better. I think it's this recurrence rate. And then there have been several studies. I hate meta-analyses, right? I mean, meta-analysis, right? You take a whole bunch of studies, you don't read any of them, you pile them up, and suddenly the pile turns into gold. If you look at individual trials, I'm still persuaded that in some cases, less is not more. In most cases of pneumonia, less is more. Probably 5 to 7 days is fine. 3 days may be fine in a lot of cases. But yeah, there was some decent, compelling studies looking closely at recurrences of Pseudomonas pneumonia. So I'm still recommending 14 days for Pseudomonas pneumonia. All right. The article, polymicrobial foot infection patterns are common and associated with treatment failure, was published in OFID. So they analyzed tissue, bone, skin, and other soft tissue, fluid and swab specimens collected from initial foot infection episodes during a 10-year period using a hospital registry. An interesting paper as they broke down these infections into categories, 3 categories. There was a Staph aureus pattern, a non-Staph aureus dominant pattern, and a pattern C. With 2 or more of the following: strep, Enterococcus, Klebsiella, Proteus enterobacter, or E. coli, and no Bacteroides or Corynebacterium. And then there was actually a no pattern group. So is that 4? It's interesting. It's not mono versus polymicrobial. These are all polymicrobial, right? Talking about polymicrobial foot infections, sort of a pathogen dominant patterns here. And what they point out is the polymicrobial pattern C, that's the one with 2 or more of the strep, Enterococcus, Klebsiella, Proteus, E. coli, no Bacteroides, was associated with treatment failure. I was speaking with one of my colleagues, Dr. Anuja Lee, a huge Sarah Dong fan, by the way, Febrile podcast fan. And we were actually just discussing how much goes into assessing and making decisions about a foot infection. Is there diabetes? What is the vascular supply? Is there obesity? Are there antibiotic tolerances? And so often we go into long courses of IV, particularly when there are these high-risk features.
Yeah. Yeah, that's why we can never answer immediately when the patient wants to leave. And they're like, oh, just throw together a quick antibiotic regimen. It's like, we can't. There's many factors. So this next paper I picked out is from Lancet Gastroenterology and Hepatology, Fecal Microbiota Transplant, FMT, for first or second C. diff infection. So abbreviated early FMT, a randomized double-blind placebo-controlled trial. This is from Denmark, where they took adult patients with their first or second C. diff infection based on PCR testing and assigned them 1-to-1 to get FMT or placebo on day 1 and between day 3 to 7 after receipt of oral vanc 4 times a day dosing at the 125 milligrams for 10 days. And then they looked at, for their primary endpoint, resolution of C. diff diarrhea at 8 weeks after treatment. And then 21 patients received FMT, 21 had placebo. And the trial actually was stopped at the interim analysis due to a significantly lower rate or resolution in the placebo group compared to FMT. So 90% of the 21 patients in the FMT group versus a third of the patients in the placebo group had resolution of diarrhea at week 8, which would make an absolute risk reduction of 57%. there were a ton of adverse events reported in both groups. It's kind of hard to interpret because diarrhea and abdominal pain were some of the adverse events. But basically, this would suggest that FMT after VANC outperformed VANC alone. I thought this was really interesting because I have imagining the groundwork that had to go into getting this trial off the ground, like regulatory issues and validating the capsules. And then it sounds like this was around the time of COVID. But it's interesting. I also think that a 66% failure rate of patients having either recurrence or death or colectomy at 8 weeks of follow-up seems really high. There are obviously limitations. It's a smaller study and was terminated early. And we still don't really have a sense of comparing, mortality and cost and how does this bear out compared to something like fidaxomicin. So I mentioned this because I think it would be a really good journal club paper if anyone is trying to prepare and hunt for an article. But yeah, I was kind of surprised at the rate of failure. But otherwise, kind of an interesting paper.
All right. The article Impact of Enterococcus Ficalis Endocarditis Treatment on Risk of Relapse was published in CID. These are the results of a multi-center retrospective study of patients diagnosed with definite Enterococcus Ficalis infective endocarditis between 2015 and 2019 in 14 French hospitals. The primary endpoint was the occurrence of relapses within the year following endocarditis diagnosis. They looked at 279 patients. About 30% received amoxicillin gentamicin combination. 41% received amoxicillin ceftriaxone. About 23% received the amoxicillin gentamicin, and then the amoxicillin ceftriaxone sequentially. 3% amoxicillin monotherapy, and 10 got some other treatments. Overall, 1-year relapse rate was 9.3%. But how did people do? The cumulative incidence of relapse 1 year after endocarditis, going out to a year here, was 46.2% for patients treated with amoxicillin, 13.4% for the amoxicillin gentamicin, 14.7% with the amoxicillin ceftriaxone, and 4.3% with the amoxicillin gent, and then followed by the amoxicillin ceftriaxone. Interesting.
Yeah. This next one is fairly quick. This was from JPIDS, Cefadroxyl use for musculoskeletal infections in an academic pediatric hospital. So cephalexin or Keflex is definitely the most prescribed oral first-gen cephalosporin here in the States. And, I think most of us know that the main drawback is that it's dosed 3 to 4 times per day, which is very difficult. And Cefadroxyl has essentially the same spectrum, but is dosed twice a day. And so I think there are a lot of fans of this on ID Twitter, for example, but we don't have a ton of data from children. And so this was a retrospective single center observational case series from Pittsburgh that took a look at outcomes of these children who received Cefadroxyl as primary oral therapy. So if they had acute hematogenous osteomyelitis, septic arthritis, and they did use the 15 mg per kg per dose twice a day with a sort of adult or max dose of 1,000 milligrams twice a day. And so they defined failure as readmission for musculoskeletal infection within 90 days or needing to change antibiotics during the planned course. Overall, there were 52 patients included and just 3 or 5.8% who were deemed to have a failure. And so they described the cases of those 3 patients. So a 94-ish% success rate, which is great news. And I think this would be a much nicer option because even though we can sneak 3 times a day dosing in for children, I think it's still quite hard for families to do 3 times a day meds. But the question is also sort of investigating cephalexin versus cefadroxyl levels in children and making sure we have the right dosing. So there is a trial looking at that that's underway.
I don't think I use enough Cefadroxyl. I just jot it down, reminder to self. Because, this cephalexin 4 times a day, maybe I'm an old dog having trouble learning new tricks. Maybe I should be learning this is a new trick. It's not a big price difference, actually, when I looked into it. So, All right. The article comparison between culture positive and culture negative septic shock patients in the emergency department was published in the European Journal of Clinical Microbiology Infectious Disease. So this is this interesting issue where a patient comes in and you make the diagnosis of septic shock, and either the blood cultures turn positive or the blood cultures don't turn positive. How do they do? What do we do? So these are the results of a single center retrospective case control study that included adult patients diagnosed with septic shock in the emergency department between January 1st, 2019 and March 31, 2020. They were divided into the culture negative septic shock, the CNSS, and the culture positive septic shock, CPSS, groups based on their culture results. The culture positive septic shock and the culture negative septic shock groups had comparative clinical outcomes, including similar rates of mechanical ventilation, 29.6 versus 32.8, renal replacement therapy, 19.3 versus 23.2, 30-day mortality, 35.7 versus 36.7, and in-hospital mortality. The culture negative septic shock group had a significantly shorter duration of days, earlier de-escalation timing of antibiotic administration than the culture positive septic shock group.
Yeah. My next paper is another review. It's from Lancet ID, infections caused by Clostridium perfringens and Paniclistridium Sordelia. People are probably going to tell me I pronounce this wrong. That's okay. After unsafe abortion. And this took a look at infectious complications of unsafe pregnancy termination, in particular, these two organisms that were mentioned in the title.
You
Obviously,
weren't
in
going
the
to repeat
setting.
them again, Sarah?
I'm going to do my best to not have to repeat them. And this is, spurred, of course, by the increasingly restrictive legislation targeting safe abortion access here in the States. So both C. perfringens and P. sordelii, hopefully I'm saying that, are anaerobic spore-forming gram-positive bugs, which are, ubiquitous in the environment, but can get in and colonize our human GI tract. And in the right conditions, they can sort of set up shop, germinate, release toxins, and cause pretty severe disease, including necrotizing infection and sort of a toxic shock type picture. And so the paper talks a little bit about this, about clinical features that you might see: fever, shaking chills, lower abdominal pain, occasionally dark, foul-smelling cervicovaginal discharge. But I think one important note is that patients with the toxic shock type picture often may not have fever, and that can be a hallmark of a severe P. sordelii infection in particular. And the authors were emphasizing looking for these clinical signs because you may have scenarios where the patients aren't forthcoming with their history or may feel uncomfortable, and so it's important for us to think about these. And so I know that I have not specifically had a Clostridium associated toxic shock scenario with a septic abortion, but I've seen it in other scenarios, and it's terrifying. And it is one of the few infections that can cause that really profound leukemoid reaction. So I think that's another useful thing to keep in mind. So a great review. It's a quick read, so people can review that, particularly if you're in one of these states that this may come up more frequently than others.
All right, very timely. The article, Prospective Randomized Trial of 2 versus 12 Weeks of Postoperative Antibiotics After Percutaneous Nephrolithotomy in Complex Patients with Infection-Related Kidney Stones, published in the International Journal of Urology. So these are the results of a multi-center prospective randomized trial that evaluated patients with the clinical diagnosis of infection stones. Patients were randomized to 2 or 12 weeks of postoperative oral antibiotics. They either got nitrofurantoin or culture-specific antibiotics, and they were included if the residual fragments were less than or equal to 4 millimeters on CT imaging after the PNL, the percutaneous nephrolithotomy. Imaging and urine analysis were performed at 3, 6, and 12 months post-procedure. The primary outcome was the stone-free rate at 6 months post-PNL. At 3, 6, and 12 months follow-up, SFRs, stone-free rates, were 72.7% versus 80, 70 versus 57, 80 versus 57. None of it significant between the 2 and 12-week groups. They also looked at positive urine cultures at these time points. 50 versus 37.5, 50 versus 80, 37 versus 100 between the 2 and 12. Really not enough numbers here for any of this to reach statistical significance. I think that's critical. The numbers were quite low. They not sure how well powered this study actually was to really put your hat on the negative results, but they did not see a significant difference between the 12-week and the 2-week antibiotic regimens. All right. Our favorite part, the fungi section. We needed this week in fungal stuff. The paper Evaluation of Serum Mucorales Polymerase Chain Reaction, PCR, for the diagnosis of mucormycosis. The MODA-Mucor prospective trial was published in CID. Seems like a good idea. The investigators prospectively enrolled 232 patients with suspicion of invasive mold disease, evaluated using standard imaging and mycological procedures. 13 additional patients with proven or probable mucormycosis were included to analyze DNA load kinetics. Serum samples were collected twice a week for Mucorales qPCR targeting the Mucorales genera Lichthymia, Rhizomucor, Mucor rhizopus. Now, this is PCR on plasma, and they report sensitivity was 85.2, specificity 89.8. I'm not sure what the gold standard was. All right. The article, Therapeutic Lumbar Punctures in Human Immunodeficiency Virus-Associated Cryptococcal Meningitis Should Opening Pressure Direct Management, was recently published in OFID, Open Form Infectious Disease. Incredibly timely, as we are currently managing a patient on our service at Columbia with this diagnosis. So here the authors prospectively enrolled 533 human immunodeficiency HIV seropositive adults with cryptococcal meningitis from 2013 to 2017 in Uganda. They assessed the association between clinical characteristics, CSF parameters, and 14 and 30-day mortality by baseline ICP, intracranial pressure. They also assessed 30-day mortality by number of follow-up therapeutic LPs performed within 7 days. 30-day mortality was higher in participants with baseline intracranial pressure greater than 350 millimeters and intracranial pressure less than 200 millimeters, as compared with baseline intracranial pressure in that sweet spot, 200 to 350, hazard ratio of 1.55, p-value 0.02. Among survivors, at least 7 days, the 30-day relative mortality was 50% higher among participants who did not receive any additional therapeutic LPs compared to those with greater than one additional follow-up LP, 33% versus 22%, irrespective of that baseline ICP. So a couple things here with cryptococcal meningitis. I've actually probably been to these facilities in Kampala. Actually shot a quick email, thumbs up to one of the authors. But things you worry about when that intracranial pressure is super high or super low, when that white blood cell in the CSF is super high or super low. And I sort of think about it as really fulminant or, ooh, your immune system doesn't seem to care. Neither is it.
Exactly. Well, this may be the only episode where I'm presenting the parasitic papers and Daniel does not have one in here. Please be sure to visit this week in parasitism. The first paper I pulled is from CID. It's the impact of extended treatment with artemether lumefantrine on anti-malarial exposure and reinfection risks in Ugandan children with uncomplicated malaria, a randomized controlled trial. And the sort of trial acronym was EXALT, extended duration, AL for the two medications, treatment for malaria in children. So this was a prospective randomized open label PK/PD study of extended duration I will say AL for Artemether lumefantrine just to make it easier, in children in a high transmission area in rural Uganda. And this is really based on prior studies that showed low lumefantrine exposure and worse outcomes based on the current recommended dosing for children. And so they compared 3 days versus 5 days of AL, and then looked at the both pharmacokinetics and then recurrent parasitemia. And so they included 177 children between 16 months of age to 16 years. They did find that the median lumefantrine concentration was increased in the 5-day regimen. And then there was this predefined 7-day lumefantrine threshold, which is based on some of the studies that I mentioned before, which was strongly predictive of recurrence risk at 28 and 42 days. So this really showed that the extended duration was safe and that there was increased drug exposure in children, although it did not lead to significant reductions in the recurrent parasitemia risk. But when you look specifically at those day 7 levels of the drug, if those were low, it was predictive of recurrent parasitemia risk. So I think it shows us that those who are low weight probably are, at higher risk of underdosing. And it seems like this is something that we could overcome with additional dosing days. So I thought that was a cool study. And then the other one is an article, Hospitalizations Due to Gastrointestinal Chagas Disease, National Registry, which was published in PLOS Neglected Tropical Diseases. And people often think of heart involvement in Chagas, but what about GI issues? So here they use secondary data from their National Hospital Information System, looking at 2017 to 2019 in Brazil, and really pointed out that this gastrointestinal involvement is and this is actually from the paper, neglected manifestation of a neglected disease. So it's just important to point out that this can cause major impacts on those patients who are affected, that they can have chronic, years worth of symptoms or disease related effects. And then the diagnosis for this is often quite late, with difficult to access treatment, sometimes inadequate treatment. And so often these patients may be operated on a more sort of emergency basis because they have a major complication because it was diagnosed late. And then because of that, have higher mortality. So just trying to point out, I think that summary was the best. Neglected manifestation of a neglected disease.
All right. And we'll just wrap it up here with 2 short papers. Well, papers aren't short, but my treatment of them. Our first prion paper. Humanized transgenic mice are resistant to chronic wasting disease prions from Norwegian reindeer and moose was published in JID. Basically, the abstract has it all. Chronic wasting disease is the transmissible spongiform encephalopathy or prion disease affecting cervix. In 2016, the first cases of CWD were reported in Europe in Norwegian wild reindeer and moose. The origin and zoonotic potential of these new prion isolates remain unknown. So in this study to investigate zoonotic potential, they inoculated brain tissue from CWD-infected Norwegian reindeer and moose into transgenic mice, overexpressing the human prion protein. After prolonged post-inoculation survival periods, no evidence for prion transmission was seen, suggesting that the zoonotic potential of these isolates is low. So perhaps I can eat those wasting hoofed animals. But the next one had me at the title and then dropped me when I read the actual results. The article, Dentist Visits and Risk of Brain Abscess, a nationwide population-based case control study. Just about to tweet this out. Stop going to the dentist when I read along. After this was published in CID, recent invasive dental procedures and number of dental visits were not associated with culture-verified brain abscess caused by oral cavity bacteria. Don't worry, I will keep looking for excuses. And if I read enough, I will one day find a great reason to avoid the dentist.
And that brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and thank you for the paper suggestions. Send them to puscast@microbe.tv. Consider supporting the science shows of Microbe TV at microbe.tv/contribute.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, end dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks.
Another Puscast is infectious.